two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checco from India.
Welcome to eCritCare podcast. This is our episode number 108, and I'm joined by my co-host, Dr. Jose Checco. Welcome, Dr. Checco.
Hi, Swapnil. Been a long time, but we are back again.
Yeah, that's right. It's been a gap of at least 2 months due to various reasons. So it's good to be back. And the topic that we have chosen today is one of the randomized controlled trial, which was published in New England Journal of Medicine and also was presented at a recent meeting in Brussels. So the trial is called as CAPE-COD, which evaluated the role of hydrocortisone in severe community-acquired pneumonia. And there has been a lot of previous discussion in the past around the role of steroids in community-acquired pneumonia. And the answer which we have received so far from various randomized controlled trials, which were really poor quality trials in the past, that there is no role of steroids in the community-acquired pneumonia. And that's the reason why we have not changed our practices for many, many years now. Except till the COVID came, we kind of found out the role of dexamethasone in COVID after REMAP-CAP and recovery trial, which showed a clear mortality benefit with the use of dexamethasone in COVID-19. And that has triggered this debate again that whether we should reconsider the role of steroids in community-acquired pneumonia. In meantime, there was another landmark trial, which was the adrenal trial conducted by ANZIC CTG, which suggested that there is a potential role of steroids in patients with septic shock to reduce the number of days in intensive care. And I guess that kind of gave a bit of signal that probably there is some role of steroids in sepsis, and that might benefit a certain cohort of patients. When you look at some of the guidelines, American Thoracic Society guidelines recommend against the use of steroids in community-acquired pneumonia, while the ESICM guidelines favor their use in patients with community-acquired pneumonia. And these recommendations are based on, as I mentioned before, they're based on really poor quality evidence in the past. One of the recently published trial was by Meduri et al., which showed no 60-day mortality benefit with the use of methylprednisolone in severe community-acquired pneumonia. And I guess one of the challenge in interpreting these trials was that the various different steroids were used in these trials, and the dose was really not standardized in all of these trials. So this trial, which is called as CAPE-COD trial, tried to evaluate the clinical question, which was in patients with severe community-acquired pneumonia, does the use of hydrocortisone compared to placebo leads to decreased 28-day mortality? So Dr. Checco, can you please walk us through the methodology and the results of this trial, please?
Yes, considering the equipoise with the corticosteroid use in community-acquired pneumonias, the CAPE-COD investigators evaluated the impact of hydrocortisone on mortality in patients admitted to ICU with severe community-acquired pneumonia. This study, it's worth remembering, was carried out before the outbreak of the COVID-19 pandemic. So the study population included adult patients admitted with severe community-acquired pneumonia across 31 ICUs in France. The diagnosis of pneumonia was based on clinical and radiological criteria. The extent of diagnostic testing to identify the pathogen was left to the discretion of the clinician. Severe community-acquired pneumonia was defined by the presence of at least one of 4 criteria, which included requirement for mechanical ventilation, either invasive or non-invasive, with a PEEP more than 5 centimeters of water, support with high-flow nasal cannula with a PF ratio of less than 300, oxygen support through a non-rebreather mask with a PF ratio of less than 300, or a score of more than 130 on the pulmonary severity index. Patients were randomized to receive hydrocortisone or placebo in a 1-to-1 ratio. Randomization was stratified by trial center and the requirement for mechanical ventilation. There were a few exclusions, which included patients with a do not intubate order, patients with influenza pneumonia, and those with septic shock. which was treated as a separate category of patients who might benefit anyway, based on previous evidence, as you mentioned, the adrenal trial, for instance. So on the intervention arm, hydrocortisone was administered in a dose of 200 milligrams per day, administered as a continuous infusion within 24 hours after fulfilling the severity criteria described previously. So they would start this infusion, give it for 4 days, and then at 4 days, they would determine whether the treatment with steroids should continue for 8 days or 14 days, based on the clinical status at that time. This was actually predefined. The dose of hydrocortisone was weaned and stopped, again, according to a pre-specified protocol, either for 8 days or 14 days. If the patient was discharged in between, of course, the steroid dosing was also ceased. In the control group, intravenous saline was administered as placebo in identical packing, ensuring blinding of the study. Common management to both groups included standard treatment with antibiotics, supportive care, and the medical team chose the modality of respiratory support, be it supplemental oxygen, non-invasive ventilation, high-flow nasal cannula, or invasive mechanical ventilation. How did they calculate the sample size? The study was powered to detect a 25% relative reduction in the 28-day mortality in the hydrocortisone group. So they assumed mortality to be 27% in the placebo group, and they assumed that hydrocortisone would reduce the mortality from 27 to 20.25%, which is a relative reduction of 25%. For this, the requisite sample size was 1,146 patients, which was rounded off to 1,200, allowing for possible withdrawals. So that's how they planned the study. And how did they get on with the study? So this study, called the CAPE-COD study, started enrolling patients in October 2015. By March 2020, roughly 4.5 years since they started, COVID-19 broke out across the world, including in France. So after this period of 4.5 years, the study was suspended and it was continued as an embedded trial renamed CAPE-COD to evaluate the effect of hydrocortisone in patients with acute respiratory failure due to COVID-19 pneumonia. So they converted the study into a study on COVID-19 patients at that time. And this study was actually published previously. We have discussed this as well as the CAPE-COD trial. So it was at the 4.5-year mark, March 2020, that they switched to the CAPE-COD trial. So they planned to carry on with recruitment once the COVID pandemic had settled down. By this time, they had 800 patients in the original CAPE-COD trial, which was all previous to the outbreak of COVID-19. But then, based on the recommendation of the Data and Safety Monitoring Board, after the second interim analysis, they ceased the study at this point, wherein they had 800 patients enrolled from 5,948 who were screened. And in the final analysis, there were 400 patients in the hydrocortisone arm and 395 in the control arm. So this study was actually conducted. All the patients were enrolled before the outbreak of COVID-19. How did the baseline characteristics compare between the two groups? Pretty much similar. Mechanical ventilation was carried out 44.5% in the hydrocortisone arm and 44.3% in the control group. So roughly similar in both arms. And the proportion of patients who received invasive ventilation was again pretty similar, 23 in the hydrocortisone arm versus 21.5% in the control arm. So the primary outcome for which the study was powered was the 28-day mortality, as I mentioned previously. The 28-day mortality was significantly lower among patients who received hydrocortisone compared to placebo. 6.2% in the hydrocortisone arm versus 11.9% in the placebo group. This number, 11.9%, is actually much lower than the predicted mortality of 27% in the control arm. So the difference was statistically significant. difference of minus 5.6. They looked at several secondary outcomes as well, including the 90-day mortality, which was also lower with hydrocortisone compared to placebo, 9.3 versus 14.7%. And they looked at number of patients who required invasive ventilation among patients who are not on any kind of mechanical ventilator support at baseline. This was again lower with hydrocortisone at 18% compared to placebo, wherein it was 29.5%. So the number of patients who got intubated who were not on mechanical ventilation baseline of any type was also lower with the use of hydrocortisone. Among patients who are not on invasive ventilation at baseline, the incidence of endotracheal intubation was also lower with hydrocortisone. And they also found that by day 28, the requirement for vasopressors was lower among the hydrocortisone treated patients. They looked at a few safety outcomes as well. Hydrocortisone, of course, steroids as a class of drugs is associated or is feared to be associated with a higher incidence of nosocomial infections. So they specifically look for the incidence of hospital-acquired infections, particularly ventilator-associated pneumonias and bloodstream infections, which was not different between the two groups. GI bleed is another problem that's commonly associated with the use of steroid. Here again, there was no difference, although the numbers were quite small. There was no difference between hydrocortisone and placebo. Hyperglycemia, as you would expect, was more common with hydrocortisone, and the requirement for insulin was also higher with hydrocortisone compared to placebo. So, in short, this study showed that although it was prematurely terminated due to the COVID-19 pandemic, it included 800 patients, and it demonstrated a beneficial effect of hydrocortisone on the 28-day mortality and a reduced requirement for mechanical ventilation and vasopressor support among patients with severe community-acquired pneumonia. The incidence of adverse events, including nosocomial infection and gastrointestinal bleeding, was similar in both the groups.
Thanks, Dr. Chacko. So truly this trial can be considered as a landmark trial because this is probably the first largest randomized controlled trial on this topic, which has given a clear signal of mortality benefit in patients with community-acquired pneumonia with regards to role of steroid. There are several strengths of this trial, and that will probably forces us to kind of reconsider our current practices. This is clearly a multi-center, double-blind, placebo-controlled trial with minimal loss to follow up, with minimal selection bias, with a very significant adherence to the protocol, with a very few protocol violations. And that really means that the internal validity of this trial is really, really high. And I think this is really well-conducted trial. Despite all the challenges where COVID-19 forced investigators to change their approach and start investigating more role of steroid into COVID rather than actual community-acquired pneumonia, they did really well. Now, if you look at the baseline characteristic, the both groups are very well matched, especially with regards to underlying conditions such as COPD and asthma, because these are the kind of subgroup of patients who usually do respond to steroids. So obviously, the authors wanted to make sure that there is no variability in these different subgroups amongst the two key interventions. Also, patients with septic shock were excluded, knowing that there is a potential benefit of steroids in this cohort of patients. So with regards to inclusion-exclusion criteria, I think they did manage really well overall separating the two groups. Now, the good thing about this trial is the hydrocortisone treatment was initiated early. And I guess that's where probably we see the benefit of steroids, because when the infection starts, there's a beginning of the inflammatory process, and potentially there is a role of steroids in that early phase rather than the late phase when there is more of a fibrotic phase and the role of steroid is questionable after 5 to 7 days of actual pathologies commenced. So initiating those steroids within the first 24 hours from the hospital admission was really a good intervention. And I think they managed to randomize patients early and got them the treatment early. And I think that's really kudos to the authors. Now, when we look at some of the kind of consort diagram, they screened really a lot of patients to include a very minimal number. And that sometimes shows the challenges around the very strict inclusion and exclusion criteria. And that means the role of steroids will be probably beneficial in a very select cohort of patients when you apply all these criteria. Challenges with this kind of criteria are some countries, they do not use pulmonary severity index, and each country will have slightly variability in terms of how the community acquired pneumonia is defined and classified according to the severity. So that probably limits a little bit of external validity of this trial. Some of the challenges with this trial, I personally think this trial is a highly underpowered trial because of two reasons. So when they calculated the sample size, they aim for really ambitious mortality reduction from the baseline with one intervention which has not been shown to have a proven benefit. And when they looked at the actual mortality they observed during the trial, it's way less than what they predicted mortality to calculate the sample size. So I'm pretty sure this trial is considered underpowered trial. And the second reason why this is underpowered is because they didn't even reach the full sample size due to various reasons. And I guess after the interim analysis, the committee or safety committee argued that adding another 400 patients is not really going to change the outcomes and probably harming the plus control group because we are not giving the intervention which is likely to show benefit. So I guess overall, this trial is underpowered trial. Having said that, the number needed to treat based on the results is around 16, which is not too bad. The second limitation, I guess, with regards to the choice of steroid and the actual dose of steroid. Now, hydrocortisone has been proven in setting of septic shock after adrenal trial. Previous trials with pneumonia were done with methylprednisolone. COVID, we found that there is a benefit of dexamethasone. So we have like this kind of variability in terms of which steroid is actually beneficial in which type of pathology. And I guess based on this trial, probably there is a role for hydrocortisone, but we don't know whether the other steroids will be equally beneficial and what's the kind of ideal dose of steroid regimen in these settings. We still need to probably explore those questions in future trials. There is one subgroup which clearly showed a more favorable benefit with regard to steroid was the subgroup where there was no pathogen was identified. That's probably the challenge with what kind of methods do you use for microbiological investigations. Do you use BAL and do you perform PCR on all BALs, or do you just take a sputum sample and do gram staining and culture? So based on the microbiological investigation method used, which was not standardized across different ICUs in this setting, it's very hard to interpret. Having said that, that signal where no pathogen was identified, where the steroid benefit was maximum, I think that's something it's quite interesting and again needs to be explored in future because this trial was not clearly powered to answer that question. And again, that comes down to when there is no organism identified, probably it's either viral pneumonia or where it's more of a inflammatory process or pneumonitis where steroids will be beneficial rather than actual infection process due to identified organism. And this trial used 200 milligram hydrocortisone till the ICU discharge. The median duration of probably administration of placebo versus intervention was around 5 to 6 days. So again, we're not sure whether less administration or more administration of steroids will be beneficial. So there are a few questions still remain unanswered based on this trial. But overall, this trial is well conducted, gave us a very clear answer and showed the mortality benefit. So I think it's definitely provoked us to think about whether we should now change our approach in managing community-acquired pneumonias in our ICUs. What's your thoughts, Dr. Jaco?
It's a very important trial, Swapnil, as you rightly pointed out, because so far, although people have been using corticosteroids sporadically in community-acquired pneumonias, there was no sort of firm evidence behind its beneficial effect. And the last trial, in fact, the only randomized trial which was conducted looking at mortality as a secondary endpoint, did show benefit, but that trial included only 46 patients. So after that, we didn't really have a proper, adequately powered randomized controlled trial. And this trial comes with numbers, although it was short of their original sample size of 1,200, it nevertheless included 800 patients, and which included patients who are pretty severe. If you go by the numbers who are ventilated, nearly 44% who were ventilated, and PF ratio was around 160 at baseline. So these were sick patients. And in this particular cohort of sick patients, they did show benefit with the use of hydrocortisone if administered early enough. Of course, there are several points which may be raised against the strength of these findings, which include, as you rightly mentioned, the non-protocolized investigation strategy, wherein the clinicians were left to decide upon what kind of investigations they would do to identify the causative agent, which obviously means that there may have been viral pneumonias, bacterial pneumonias, and different types of pneumonias. And you couldn't really tell as to where did the difference come from, and in what sort of clinical situation would it be most beneficial. Of course, COVID-19 was an eye-opener for all of us. And for the first time, we found that in a viral pneumonia, steroids may be beneficial with the recovery trial and several other trials after that. And people were using corticosteroids in hypoxic patients extensively during the COVID-19 pandemic with positive results as well. The other important question that you raised was regarding the type of steroid, where again, there is no common consensus as to what may be the most appropriate steroid. In COVID, of course, they used dexamethasone as a random choice. And the question still remains as to whether one type of steroid would be particularly more beneficial compared to the other. And of note is a recently published RCT which compared fludrocortisone, which is a mineralocorticoid, and hydrocortisone combination compared with hydrocortisone alone in patients with septic shock. It published in a JAMA Internal Medicine just a few days ago, which showed benefit with the combination of hydrocortisone plus mineralocorticoids. So whether any such difference would exist in community-acquired pneumonia also would need to be explored. But on the whole, this study provides a very strong signal that corticosteroids may benefit if administered early in severe community-acquired pneumonia.
That's correct. That's probably the key take-home message, that at the moment, based on this trial, it's safe to use hydrocortisone in stress dose, what we normally use, 200 milligram per day, in patients with community-acquired pneumonia who are requiring intensive care admission or mechanical ventilation. And I think that's probably the safest thing to do. And again, trialing steroids for 4 to 5 days and see the benefit. Obviously, if the patient is not benefiting from the steroids or getting harmful effects due to steroids, then definitely that's something needs to be considered to be stopped. One of the other side effects that was not evaluated in this trial was the neuromuscular weakness impact based on the steroids, and whether that has any impact on more tracheostomies or more prolonged ventilation. Those were probably the secondary outcomes that needed to be powered adequately to answer those questions. It seems like there's a mortality benefit with hydrocortisone in pneumonia. And at the moment, it's probably safe to say that there is no harm in trying that treatment. So it's definitely going to change my approach in patients with community-acquired pneumonia who require mechanical ventilation. What's the impact of this trial on your practice, Dr. Shekhar?
Yes, in fact, as I mentioned, given the obvious beneficial effect of dexamethasone during the COVID-19 pandemic, in fact, the practice, at least among some of our clinicians, has changed with the propensity towards early use of corticosteroids in other types of pneumonias as well. Whether that was justified or not at that stage was difficult to tell. But now, of course, with this evidence, there is, I think, enough justification to use corticosteroids early in severe community-acquired pneumonias who require ICU admission. I think whatever signal we had from the COVID-19 pandemic would perhaps be extrapolated to other types of community-acquired pneumonias as well.
Yeah, that's correct. And I guess still there are other randomized controlled trials which are on currently going on. And I guess probably the most important will be the REMAP-CAP and REMAP-CAP trial, which has got this adaptive platform design, which will be probably more relevant to investigating the treatments like steroids in community-acquired pneumonia, because that design will probably more beneficial compared to a simple randomized controlled trial design. And also the Bayesian analysis will be probably useful I guess there's still few moving pieces of this puzzle, which will probably unfold over the period of time. But I think till that point, it's safe to say that it's probably time to change our practices. So that's the end of our today's episode. We'll be back with another episode in fortnight's time. Till then, goodbye and have a nice time.
Thanks for listening. Thanks, Swapnil. Thanks, everyone. See you next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.